Those are my disclosures. You've seen this slide before, and what you're going to get more in this talk is a little bit of philosophy. After about 15 years of trying to roll this out in 4 different institutions, I can assure you I have clearly seen the movie. I know how it ends, unfortunately, and unfortunately I'm up with a new audience each time, so I already know what the movie is going to look like. We just have to get to the end of the movie. So I'll quote Machiavelli, who had a variety of very cogent descriptions of human behavior, but I think this is probably the most cogent. And this has been paraphrased multiple ways, but this is the actual quote. And the paraphrase to this is, when you want to change something, you are actively opposed by those who stand to lose from the new order, and you barely have friends from the ones who are going to profit. So basically, no one wants to help you change. It's just you. But this is the problem. We saw great data from Ollie. We saw a variety of data sets earlier in the discussion, and there's just clearly different outcomes. And it's great if you're on the left-hand side of the curve, then you don't really have much issue. But something's very different about the folks on the right hand. But I guarantee you, as we heard in the audit description, if you ask the people on the far right, they're pretty sure they do everything that everyone else does. And clearly the outcomes are not the same. So you really have to, again, be very introspective in this whole process as you try to improve the overall quality, and you have to measure yourself. That's the only way to really know that you've changed something for the better. And you've seen this again, and again, this is just a huge opportunity in colorectal surgery, and remains so because of the relatively slow adoption, primarily in the States, for enhanced recovery. So I want to use a quote from Margaret Thatcher, who said that consensus is the abrogation of leadership. And so on this slide, you can see, of course, I never question authority because I am authority. One of the major challenges in getting things going is that a lot of the vote on democracy just flies in the face of the obvious data. And so I reach out to groups that try to change over time, but the change is much slower if you have to get people to agree on what the obvious data is. And so I think one of the early game plans you have to set is that no one gets to say, I always, I usually, I did, but you have to come with something that proves that you're right if you want to put that in the program. I found that decreases the conflict and decreases the time to change because no one can come with their opinion. They have to have some piece of data, and if they don't know, then that's a reason for something for the group to study, but they have to come more often prepared for a real discussion. So we've already heard the various components that can be debated. I think some are more obvious than others in terms of how they impact the overall outcome. But each of these has a variety of measures, and you can see how this could get very daunting for the new initiate very quickly. You start to put 4 or 5 changes in each one of these boxes, it becomes unwieldy to get anybody to try to master the transition, and so the natural human response is to just back off and not engage. But clearly to get somebody engaged has huge benefits. And again, this shows the overall outcome of taking a group who remained resistant despite the evidence. And their outcomes continued to lag by not adopting the new approaches to the postoperative care. And so at some point, I will tell you in the States, in the next couple of years, this just won't be sustainable for an organization. You won't be able to absorb the variation in outcome that leads to invariably variations in cost and stay competitive in the new market. You're going to have to refine around what works, what leads to better outcome, and what leads to better cost activity. And this is a slide that shows an assessment. So if you were running a business, this would be the contribution margin, which in the for-profit world would be profit. And the place to be is in the right upper quadrant. Clearly a significant outlier for laparoscopic and enhanced recovery compared to the other versions of the care plan. You would never tolerate this if you were making widgets in a factory. You would shut down the other punch presses, sell them, and go buy a bunch of the new ones because of the better outcomes. These kinds of data need to be shown to the team regularly to help drive the changes because, again, you can't absorb this kind of variability. I talked a little bit earlier about the cost structure, and this looked at it a different way. This is a little bit older terminology because instead of the 331, 330, 329, it was DRG 149, which was healthy, no complications, and 148 was either sick to start with or you made sick. What this slide shows is that when you compared how they came in the hospital. Laparoscopic is on the right-hand side, and the pie on the left is open. Half of the patients in the open cases came in that lower DRG, but left the hospital with complications that moved them to the other. That doubled the cost structure to the payer for health care for that population. You could never go and compete if you were selling a product. You could never compete if 50% of the time your product costs you twice as much to make compared to the competitor. So you can see that a lot of the advantages of enhanced recovery actually control cost migration. So again, another reason to think about including it. Does it work? So this was some time that I spent in Toledo, and we looked at some historical comparisons before and after. And you can see the story is the same as most of the speakers have shown. Significant reduction in length of stay, significant reduction in complications, lower cost structure. Why would you not adopt this? And it gets to be the challenge again of, well, it's one of the things, I didn't invent it, I didn't see it, it's not what I usually do. These are the kinds of barriers you have to really break down by collating the data up front and explaining to people what the outcomes are. They can do different processes. It isn't so much being married to a specific process if you get the same outcome. This was an interesting study that we did when I was in Grand Rapids, and we were struggling a bit in rolling out the program. So we took a really low bar. We said if you fed the patient the day after surgery, which was on our protocol, and you used all the components of the narcotic-sparing analgesic, we would consider that victory. We didn't care about the rest of the care plan. We just said if those two things happened, we'll use that as a marker. So what you see here, and if you didn't do those two things, just those two things, you failed the ERP. So you can see the difference in length of stay if you stuck with those two really simple things. We then asked the nurses, because one of the reasons to fail the proactive pain program was the belief by the nursing staff that the narcotics were simply better for the pain. We were making the patient suffer. So this wasn't a study. This was based on the actual Visualog analog pain score that the nurses collected as a matter of routine, because this was retrospective. When we showed the nurses the fact that if they stayed on the real program, their pain scores were actually lower. So we were effectively treating the pain. You weren't treating the pain with the going off the reservation using the narcotics. So again, it was a good education to show them this was their own data, their own evaluation of the outcomes, and they were seeing a dichotomy. Similar in complications. Just those two simple things that I mentioned, failing to do those two things led to a significant increase in complications. Clearly, there were some other things that probably went along in terms of compliance, but it shows that just picking a couple of things to measure can really show two very different care populations. And then even the anastomotic leaks were different in the two groups. This was compelling because, wow, maybe some of the things we're doing actually improve healing, actually change one of our worst feared outcomes by staying on the protocol. So again, these are just real world experience. It wasn't prospective randomized data. It wasn't a highly structured assessment. It was really a very simple assessment of a very simple program and how different the outcomes were. This is, again, somewhat lagging. In this group, it probably doesn't play well, but still in the States, a good 55 to 60% of colectomies are done open. It doesn't mean you can't do enhanced recovery, but you will lose some of the benefit that is attributed just to the laparoscopic approach. So it really is that stair step of laparoscopy when it works, the care plan all the time, and the results will be better in that laparoscopic group with enhanced recovery. But it just shows it's not a protocol, and Ollie showed some good data about adoption of various components. You already know that I'm in the pro Bowel Prep camp, so I would fail this measurement tool routinely. But you can see that not everything is always followed, yet teams can still get the good results. So I think we probably still don't know what are the core concepts, the drop-dead items that need to be implemented. I think the other things all give some marginal value, but there are probably 3 or 4 important things in there that you simply need to adopt. We talked again about routine, and again, if you ask everyone, I do a little bit of visiting professors, and I always end up rounding with the residents, and they say, well, we never have any post-op ileus, and every third person has an NG tube. And well, why is the NG tube in? Oh, well, they just vomited a little bit. Well, isn't that an ileus? So we get blinders on about what we do, and routinely still do things that we think we don't. Same to general diet. Everyone says they feed their patients early, but no one seems to have a diet ordered. And I think in a lot of places it's still the regime of a day of clears, a day of fulls, a day of soft, and then a day of regular diet. Drains, you saw this earlier again, expensive to use and don't prevent any of the complications that you think they do. Epidurals, I showed this before as well. But here's an interesting one, because I'll just pick on the bowel prep thing since I get a chance to be on the podium here. This was an interesting assessment of rolling out the enhanced recovery protocol. And one of the things they did is they went away from their standard bowel prep of mechanical and oral antibiotics and adopted the no bowel prep technique. Their SSI rate went from 24 to 44%. So again, if you don't assess your outcome, they actually went back to the old protocol after they saw their own data. But this is, again, if you don't measure what you did, it's okay to make a change. It's okay to roll out something new, but you need to be sure it actually works out the way that you want it to work out. Again, the process measure versus outcome. I would argue strongly in favor of outcome measures. The processes are nice if you know for sure that process goes to that outcome. But if you just measure the outcomes, you don't really have to worry about it, because if the outcomes are all good, you know your system is tight. When an outcome fails, then you can go back and look at the feeder processes. It just makes it more efficient for the team. And you've seen my version of a FastTrack protocol. Again, all these things are very simple. They're much easier on the nursing staff, much easier on the patients, and really fairly cheap and easy to implement. And you saw the education tool and the order set. I believe very strongly that you need the standard order set, because it's very hard for someone to go out of their way to order something that isn't on the menu. So one good way to drive the team is make it really hard to go off the menu. I don't really care what you choose on the menu. You can be, as independent as you choose there, but at least you're on the menu for everything we've agreed is appropriate to use. And again, this is some interesting work by Don Fry, looking at what really matters. And this is just looking at cost as a measure. The lowest cost was no complication and no adverse outcomes. Next was a complication that wasn't very serious, and the worst was a complication with an adverse outcome. And so just measuring simple, very things like length of stay and cost of case will give you a very high-level view of when your system is not under control. And when you have that group that's out of control, that's the group to go focus on and say, are you implementing your process measures? So, clearly this is a win-win for everyone. So it's really a mystery why it is persistently so hard to roll out. And it says something, I think, unfortunately, about medicine, because no industry would go on like this with their production program. They would figure it out in 30 days or not be in business. And so we really have to focus on the fact that this is just better for everyone. Everyone has to check some of their religious beliefs at the door and focus on the new approaches that work for everyone. And again, I think we've heard, very clearly from all the teams, it's evidence that drives the decisions, not emotion and not belief. And so you can't compromise on something when the data says do this. There's no compromise around the data. I'll leave you with a quote from Max Planck. I think, unfortunately, this is probably truer in medicine than it is in some other things, but it is a driver of human behavior. Thank you.